Welcome to Optimity Advisors Integrated Care webinar series. My name is Niamh Lennox-Chhugani, and I'm going to be with you for this first webinar. This webinar series has come out of our most recent work for the EU Commission, building on 15 years of work researching and supporting the implementation of integrated models of care and population health internationally. This is the first of a series of 5 webinars based on our review of integrated care across the 28 European Union member states, Norway and Iceland, funded by the EU Health Programme. First, we focus on why integrated care has emerged as a universally recognised health system initiative. We define integrated care as including initiatives seeking to improve the outcomes of care by overcoming issues of fragmentation through linkage or coordination of services along the continuum of care. Successful models of integrated care start with robust data and insight that lead to action. By using data and insight related to current population health and the wider community resources used to meet them, successful models of integrated care set themselves up for success. Integrated care should always be delivered in the context of wider population health, which addresses the determinants of health. But integrated care and population health systems are not synonymous. Delivered together, models of integrated care in the context of population health systems transform a health system from volume to value, reactive to proactive, and focused on ill health to focused on wellness. The drivers of integrated care are well rehearsed in the health and social care literature, but there are differences in emphasis in different European systems, and this was illustrated by our sampled country-level interviewees. All systems in Europe are experiencing the changing burden of ill health in the context of health systems designed for a historic pattern of ill health. The vast majority of integrated care models we identified across Europe focused on older people living with multiple long-term conditions. Increased pressure on emergency care services has been experienced in the UK and Ireland, with public pressure to address the issue. In Ireland, we identified a model called CareDoc that was set up in 2010. It was set up in response to overburdened acute care services in Carlow-Kilkenny regional hospitals. Community intervention teams supported early discharge of acute yet low-risk patients to community-based care. Over 142,000 patients living in the Carlow-Kilkenny region have access to these teams, and the initiative continues to expand coverage across the southeast of Ireland, funded now from the Health Services Executive Budget. 2,300 hospital bed days were saved and 215 ambulance call-outs were avoided, resulting in 50% cost savings during an evaluation period of 2 years in 2012 and 13. And patient satisfaction surveys report that 100% of patients regard the community intervention team service as excellent or very good. The costs of healthcare are increasing in all countries. We did not, however, find that this was the dominant driver for integrated care across Europe, but rather there was a focus on a better experience of care and higher quality care, leading to better health and well-being outcomes. That in turn is believed to have an effect on containing costs in part of the health system. Many contributors pointed to the effort to shift resource allocation away from hospital care to what is assumed to be higher value prevention. Health systems that follow the Beveridge model, such as the UK, Spain, and most of Scandinavia, put a heavy emphasis on health inequalities. This is seen to be rising in some countries, and integrated care could provide a means to addressing it. population expectations of care systems are changing. An increasing number of people expect to be active participants in their care. A programme in Denmark focused on chronic obstructive pulmonary disease, or COPD, used telemedicine to support patients self-manage over 4 months, resulting in a 54% lower hospital readmission rate for the target group. Patients enjoyed learning about their condition, felt empowered by new knowledge, were secure receiving treatment at home, experienced a greater sense of control over their health, and were motivated to perform recommended preventative exercises. In summary, the assumed and in some cases evidence-supported benefits of integrated care are better health, better value for money, improved workforce experience, and improved patient or citizen experience of care. What we know from this and other studies is that there are patient experience benefits, as we saw in the examples from Ireland and Denmark. There is evidence of changes to hospital utilisation, with reductions in avoidable admissions in most cases. There is some evidence that changes in utilisation are reflected in cost savings, but this is offset in many cases in the first years of implementation by the requirement to invest in community-based services. So far, there is limited evidence of better population health outcomes in Europe, as few initiatives have included prevention and the wider determinants of health. As the Braveman model of social determinants of health shows, many of the current models of integrated care focus only on the medical care and personal behaviour. The next generation of integrated care will need to reach wider than this to deliver population health. In South Karelia Social and Healthcare District in Finland, they replaced conventional healthcare centres with well-being centres, which offer social and healthcare services based on the needs and age structure of the population of each service area. This meant combining primary and secondary healthcare, elderly care and social care to promote health and everyday well-being and functioning. It integrates acute hospital, primary care and social services, provides coordination in strategy, financing and investments by the 9 owner municipalities, and has a common workforce and recruitment strategy. Mobile services support the operation of wellbeing centres and low-threshold service centres. It uses special workers, mobile teams, and a clinic that provides nurse and oral health services to the district's remoter areas. All information concerning primary or secondary care, as well as dental health records, can be found in the same place. The programme has delivered productivity, which increased by almost 50% in direct patient visits, very high measured patient satisfaction, implementation of electronic resources in home care, such as real-time shared electronic patient records that can be seen in hospital and primary care. Reductions of costs of 15%. There are challenges ahead for integrated care. There's a need to move from relatively small-scale programs and projects to system-wide initiatives. This is a political as well as a technical and financial challenge, but the appetite is out there across Europe. Please join us for our next webinar, which will explore the contexts in which integrated care flourishes across Europe.